Good morning, everyone. Thank you for making your way out here this early spring morning. We're really excited to see everyone here today. And thank you for joining us on the webinar. As Dr. Madasser mentioned, this is the first in a series of 3 grand rounds being hosted by our residency program through the generous support of the Nicholson Foundation. My name is Dr. Julie Pantlick. I'm an internist and one of the clinic faculty here at the St. Francis Medical Center in Trenton, New Jersey. I work with the residents in our outpatient clinic where annually we see about 3,000 patients. Working with an underserved population, whether it's here in Trenton or anywhere else, you quickly learn to be grateful for the $4 prescription plan. Then you tell yourself, well, at least you have the hope of treating the common triad of high blood pressure, high cholesterol, and diabetes. But there is another sort of triad that exists, and maybe this is a little bit of literary license, but insomnia, depression, and substance abuse. These are very significant problems for which underserved communities have no easy solutions. Medicines are available, but the menu is limited on the $4 plan. And more importantly, medicine, as we know it, has side effects. It has interactions. It causes sleepwalking. Someone just told me it causes sleep cooking. It's daunting, really. So medicines don't always work, and they're expensive, and even if you do prescribe them, your patients may not be able to afford them. So when it comes to behavioral health, the longer term, frequently more effective options such as psychotherapy, drug and alcohol rehab, and lifestyle changes, they're not always an option. And that could be due to human resource problems or financial resources. So the Nicholson Foundation is enabling our clinic to pilot some new approaches to behavioral health, which brings us to why we are all here today to learn about Dr. Nora Vinson's work. But before we get started, a few housekeeping items on the CME and how to file for your certificate. I'd like to read the CME slide here to you. Essentially, to claim the CME, whether you're a physician or a non-physician, you need to have signed in. Please write legibly, doctors. And we will forward you the appropriate link for you to complete the survey after the event. After you complete the CME survey, you can go online to print out your certificate. Please note at the beginning of the survey, you must answer the question where you claim your credit and how much credit you're claiming. The CME slide. So these are disclosures. There's no financial disclosures. Dr. Hugh Bonner, myself, Brian Keenigan, Dr. Nora Vincent. So you can go on to the next slide, please. Oh, I have to go on to the next slide. Sorry. So regarding continuing medical education credits, for today's presentation, the Medical Society of Delaware designates the CME for a maximum of 1.5 AMA PRA Category 1 credits. You should only claim the amount of credit that reflects the extent of your participation in this activity. And within the next week, you'll receive an email with a link to an online evaluation. You must complete the evaluation to receive your credit. Please claim your credit and complete the post-test. When you finish the evaluation, you'll be able to print out your CME. So Dr. Nora Vincent is here today from Manitoba, Canada. Her CV is very impressive. She's received both a master's degree and a PhD in clinical psychology from the University of Manitoba. She has received numerous academic and clinical awards, including a 2010 Leading Practice Award. She's been writing and receiving grants for her own research since 1999 in the area of insomnia, comorbidities including fibromyalgia, anxiety, depression, and type 2 diabetes. She's written articles for journals, including the Journal of Clinical Sleep Medicine, Behavioral Sleep Medicine, Canadian Psychology, Behavioral Research and Therapy, and the Journal of Sleep Research. Dr. Vincent is currently Associate Professor in the Department of Clinical Health Psychology Faculty of Medicine in the University of Manitoba, where she teaches. Dr. Nora Vincent is the developer of Restore, which is a computer-based CBT for insomnia program that received international attention when the data from its randomized clinical trial titled Logging On for Better Sleep, randomized controlled trial of the effectiveness of online treatment for insomnia, was published in June 2009 in the journal Sleep. It was reported on in the New York Times, Time Magazine, US News, AOL, and MSN, and has been very well received. I'm very excited to introduce you to her now. Dr. Vincent, welcome.
Thank you. It's my pleasure to be here today. As Julie mentioned, I come from central Canada in a region that's a population of about 750,000, and I work in the largest teaching hospital in the area, in the most marginalized area of the city. So we see the poorest people, with a large number of those folks being diverse from diverse areas, such as the Philippines, a lot of Middle European, Mid-Eastern countries. So it's a very nice place to work because we see a lot of different kinds of people with different cultural backgrounds. So what I'm going to talk to you today about is treating insomnia in primary care. Before I get started, I'll just mention that as mentioned, I'm a consultant for Cobalt Therapeutics, and I also receive grant support from the Canadian Institute of Health Research, which is the parallel to NIH in Canada, as well as the Health Science Centre Research Foundation at the University of Manitoba. So today I'm going to talk to you about insomnia, what are the costs associated with not treating this problem. I'll be talking to you about the treatment options for this vexing difficulty, as well as the effectiveness data that points to those treatment options, who are good candidates for treatment, what is the impact of treating sleep on comorbid conditions, how accepting our patients of these options, and how can this treatment be delivered more effectively in a primary care setting. Okay, so most of us are familiar with the problem of insomnia. Most of us have had this problem once in our life, maybe multiple times. The definition currently is difficulty with falling asleep, staying asleep, awakening too early, and now it also includes non-restorative sleep. So we think of someone as having insomnia, even if they're not awake for an extensive period during the night, but merely waking up feeling very non-refreshed is enough to make us think that person has insomnia. Additionally, we think of someone having an insomnia disorder if they are having trouble functioning during the daytime. And most commonly, what you hear is people who are overly fatigued, difficulty concentrating, irritable, impatient, that kind of thing. So, how common is this? Extremely common. In fact, some people have referred to insomnia as becoming an epidemic. 40% of people from various countries around the world report having difficulty with sleep, which probably comes as no surprise to you working in primary care. Of that 40%, we think about 9% of people have accompanying daytime impairment. So 9% of people in epidemiologic studies look like they have insomnia disorder. Now, the rates are much higher in primary care because you're seeing people that are seeking help for different kinds of health problems. So the rate here, it looks like it's around 69%, with about 19% meeting criteria for insomnia disorder. What is surprising is that only 52% of patients will actually tell their primary care physician about their sleep problem. Now, why would this be? Well, there's been some studies that have looked at talking to patients and talking to physicians about their experience of talking to physicians about insomnia. And what the patients talk about is, in preparation for this appointment, they need to convince the physician of the seriousness of the problem. So patients are feeling like, I need to really get this across that I've got a really bad problem sleeping. In addition, I might have other problems with hypertension, diabetes, but my sleep is really bothering me. The other thing that focus group data has shown us is that these patients might be thinking of approaching the physician about a medication, but they're quite open to other options, even if they are a medication user. When we talk to physicians, physicians often report that their experience with insomnia patients typically involves assessing for underlying causes and expect expectancy that patients will be resistant to discontinuing with their medications. Does this fit people's experience in the clinic setting with patients? Yeah? Okay, yeah. I thought it was quite appropriate too. I thought that matched up well. So one thing to know about insomnia is over the past few decades, it has really been viewed to be a symptom rather than a disorder in many areas. In thinking about this problem, I asked some of my medical colleagues if they could think of, in the history of medicine, other problems that we initially viewed as symptoms and didn't take overly seriously, and it was only later that we began to see the negative ramifications of not treating that symptom. And I got some amusing replies. This is an email reply from someone who said, I didn't get a chance to ask her physician husband last night about this kind of parallel, because we were both out and too tired to talk when we got home. The second email, I wasn't able to think of anything that fully fit the situation, but he's been pretty exhausted most of the week. So I thought that was kind of funny in trying to think of some examples that physicians, like the rest of us, are extremely tired a lot of the time. But I think the parallel that does fit not badly is fever. For many years, we thought of fever simply being a manifestation of infection, and the thinking was just to let it run its course. And it was only later that we realized that, in fact, we need to treat fever in vulnerable people or they're going to develop seizures. So fever is not a bad parallel with insomnia. And we know with insomnia, if we leave insomnia untreated, there can be many adverse consequences, of which I'm going to review for you now. So the sleep community has done a rather bad job of assessing the costs of untreated insomnia. And partly this is because people don't report insomnia to their physicians as often as they should be. And so it's difficult to get an accurate sense of how much insomnia is costing. However, some studies have been done more recently estimating that insomnia is an extremely costly problem, costing the US healthcare system $13.9 billion in '95. And more recently. And the bulk of this cost seems to go with healthcare service, followed by prescription medications. And what we know about that is that a large portion of the healthcare cost has to do with nursing home admissions. And in fact, one of the earliest studies on this topic found that about 20% of nursing home admissions are due to caregivers' difficulty with managing their elder relative's sleep problem. In fact, the elder's sleep problem was the biggest contributor to their decision to send the relative to a nursing home, even beyond falls or other medical complications. Two studies have been conducted in the last several years, asking people who are members of insurance plans to look through their records, and in this particular study in 2007, we looked at 138,000 adults with insomnia versus a matched control sample, and went back in the past 6 months and looked at some of their healthcare costs, the direct costs and the indirect costs. So indirect costs of insomnia can be things like missing work or having to go on short-term disability. What they found was that over a 6-month period, the costs were just a little over $1,000 greater for a person with insomnia than a matched control. Did that surprise anybody? And that number, when I first looked at it, surprised me a bit. I thought, that's quite high. And I think that's good to have this data because for many years we had no idea how much insomnia was costing individuals. The second study, conducted in 2011, also assessed members of an insurance plan in the Midwestern US and looked at a sample of about 1,200 who had an insomnia diagnosis versus a matched, randomly selected, control group. And they divided the insomnia group based on how severe their problem was, from sort of sub-threshold to severe or moderately severe. What this study found was the annual direct costs of having insomnia, having sub-threshold insomnia, were $912. And again, that figure of just over 1,000 for moderate severe insomnia. And folks without insomnia, their healthcare costs were only $643. So again, I think this provides a very interesting illustration of the expense of having the problem of insomnia. So the costs were 75% larger for the group with moderate severe insomnia relative to the control group. Many folks with insomnia, although they don't talk very often with their physicians about the problem, are still going to see a physician significantly more often than good sleepers, so 10 to 12 visits per year versus 5 visits for good sleepers, and are more often being hospitalized. So 21% for severe insomnia and 12% for good sleepers. Many costs also relate to losses that speak to insomnia, so problems with attention and concentration, difficulty with managing our emotions, deteriorating quality of life, accidents, and as I mentioned, being absent from work or not advancing in work. So these are some of the indirect costs that patients will often talk to us about during the healthcare encounter. For quite a long time, we thought that patients were making more of the cognitive impairment than was actually there. So, in fact, some of our models thought we described this as sort of an amplification or a catastrophizing, which I think we all feel fairly regretful about now, because now the data quite clearly shows that if you look at immediate attention, people who are sleep deprived can perform fairly similarly to people that are good sleepers. But if you ask them to sustain their attention for, say, more than 10, 15 minutes, you see a real noticeable impairment. And in fact, this is, if you're familiar with the effect size metric, which is a way of quantifying the size of an effect, then we think of effects greater than 0.8 as being large. This is a very large effect. So when patients talk to you about having difficulty paying attention and concentrating, we now have good evidence to suggest that, in fact, that's exactly what's happening for them. Other kinds of impairments that we found in the literature are fine motor coordination, moderate impairments in executive functioning, which is the ability to inhibit our most immediate response and to plan, moderate impairments in visual processing, but no impairment in general intellectual or verbal functioning. So people who talk about being too impulsive, saying things that they shouldn't, getting themselves in trouble, again, it's quite likely that that may be due in part to the sleep disorder. This is one of the most interesting studies I've looked at over the years. It comes out of a lab in the southern US, where they looked at the impact of restricting people's sleep over a 2-week period. So normal sleepers were allowed to sleep for 8 hours, and another 2 groups were, their sleep was restricted to 6 or 4 hours. And one of the things that they noted here was that there were cumulative dose-dependent deficits in vigilance and working memory as the study progressed. So what that means is the deficits in attention span got worse over time as the study progressed, and same with working memory. However, subjective reports of sleepiness from these individuals increased acutely as their sleep was restricted, as we would think, but then leveled off on subsequent days. So what that means is people are very poor discriminators of how sleepy they actually are, that we tend to sort of habituate to sleepiness, and we fail to report it. So I think this is very important because it suggests that people may not be aware, really, of the enormous impact that the problem is having on them. And it may explain why huge numbers of people are falling asleep or nodding off while driving. And a study in Canada in 2006 showed that 1.3 million people self-reported falling asleep or nodding off in the past year. And unfortunately, it's not much better in the US, with a poll finding that 37% of adult drivers admitted to falling asleep in the past year. And it's, of course, likely that this number is an underrepresentation because there's likely many people that are not aware of this problem or acknowledging it. There's costs of disturbed sleep that extend to the workplace, where we find that those with insomnia are twice as likely to miss work because they haven't slept the night before, and it's particularly true for managers and for females. And that insomnia will predict in a prospective study how many days of sick time a person takes. And some other folks have quantified this to say that 1 week of poor sleep is associated with a 3-fold reduction in productivity at work based on self-report data. Similarly, aside from not being present at work, when we are present, we may be much more likely to have accidents at work. And this was a national telephone survey, Users of a Health Plan, published in 2012, where they asked people whether they had been involved in an accident at work that would have cost the company greater than or equal to $500 in the past year. And they also assessed the presence or absence of insomnia on this telephone survey. Well, what they found was that the average cost of accidents that were reported, which related to insomnia, was $32,000 in the past year, versus other types of accidents where the cost was $22,000. So insomnia in this study related to 7% of all costly workplace accidents and costed about a quarter of the cost of those accidents. And most interestingly, insomnia was more costly than 17 other chronic conditions assessed. So if you think that insomnia is not costing you much as an employer, you're probably mistaken. Similarly, many of us, when we haven't slept for a long time, just feel unable to work. And this is a study in 2009 that asked 6,600 working adults in Norway, I believe, to look back on their data and follow them up for 4 years, and found that insomnia predicts permanent work disability fourfold. So what that means is if you have insomnia, you have a fourfold chance of being permanently disabled. And that was true even after controlling for the number of sick leave periods you might have had at the baseline period. And that effect remained even when we adjusted for how many hours of sleep a night a person got and other types of confounds. So you have a twofold risk if you got insomnia for having disability at work, which is a serious problem. Many of us find that we have periods of time during the day when we're not productive. So if I had to ask the audience today, how many hours do you think in a week you might not be very productive at your job? I realize some of you are students and your mentors are here, so that may be uncomfortable. So maybe I'll ask the mentors that question. How many hours per day do you think you might be effective? 2 hours? Okay. Anybody else have a guess or thought? Okay. So actually, when we ask people without insomnia how many hours in a week that they're not very productive, they say 6.2 hours a week, which costs about, on average, according to this costing, $1,000 to the company. When we ask people with sub-threshold insomnia, so they've got some problems, more nights than not, but it's not every night, how many hours of lost time do you think these people report, if you had to guess? 10? Okay. Very close, 8.5. So these people feel like it's costing them a day a week of productivity. And the moderate and severe group feel like it's costing them 9.4 hours a week of lost productivity. So clearly, having a problem with your sleep impacts our perceptions of how much we're able to do at work. I think this data is very interesting. Many patients with insomnia talk about feeling weepy, I can't control things, I just can't manage as well as I could. And in fact, there's now converging lines of evidence that show that sleep deprivation worsens mood and makes us more irritable. In 2003, though, there was a very interesting study that looked at how responsive we are in our brain to negatively toned stimuli. So this was a study that had healthy sleepers, deprived them of sleep for about 35 hours, and then brought them into an fMRI and showed them some series of pictures ranging from neutral, innocuous images to very upsetting, violent images. And here's a picture of their brains. So the control group was non-sleep deprived, and the guys on the right were sleep deprived. There was 60% more activation in the sleep deprived individuals in the presence of those upsetting visual cues. So here's some interesting also illustration of the impact of sleep deprivation on our functioning, brain functioning. Many of you see people with alcohol problems, anxiety disorders, mood disorders, and there have been now a number of large-scale epidemiologic studies that show that having insomnia predicts the subsequent development of these problems. And the odds range from 1.5 up to 5-fold. So insomnia is now being viewed as a very significant predictor for some of these issues. For alcohol, some of the people that we see who don't sleep turn to alcohol because they feel it helps them to fall asleep. Similarly, for people with mood disorders, we know that about 70% of those people have had prior insomnia, so it's quite clear that the insomnia predates the emergence of the full-blown mood disorder. In the case of anxiety disorders, it looks like the anxiety problem more often will begin first, but then both will become unfortunate bed partners for a long time. And more recent data is showing that insomnia, severe insomnia, is one of the best predictors of suicide that we have. We don't have very many good predictors of suicide, but insomnia is one of them. And more recent studies show that that might be mediated by nightmares and by sort of hopeless thoughts that a person can have, which we all know, if you're not sleeping, your ability to cope with anything and to even think about problems is very diminished, right? So if you're down already, thinking about your life and whether it's worth living is just going to become more intensified at night. Similarly, a lot of the common problems you see in primary care, diabetes, hypertension, stroke, obesity, AMIs, insomnia has been shown to be a major risk factor for developing these difficulties. And these are all large-scale studies with long follow-up periods with adequate controls. So they've controlled for baseline confounders. So again, odds ratios ranging from 1 to 2.5. Then several years ago, some of you may have been aware of this data, there was a number of, again, very large epi studies showing that sleep duration also was a big predictor of mortality when we follow people for 10, 15, 20 years out. That there seemed to be a band or an interval of time that was most adaptive for people in terms of mortality, and it looked like it was somewhere in the 6 to 7 hour range. And of course, many people we see with insomnia are short sleepers, and so it's also a risk factor for mortality. So just to conclude, the costs of insomnia are large in scope, have largely been trivialized, are not known for many years. And now we know that the costs of not treating insomnia are huge for the individual and for the society at large. One of the issues with treating insomnia is that there are so many things that can cause insomnia, and insomnia is a symptom of so many problems that it is very difficult to know what is causing this problem or what's an effect of this problem. And here's a list of some of the medications that can lead to a person having difficulty with sleep. Even antidepressants, many of them can make a sleep problem worse or cause it to begin. And similarly, there's many medical conditions where insomnia is a very significant player. Cancer, Parkinson's, incontinence, gastro reflux, obstructive pulmonary disease, other types of sleep disorders like restless legs, many different kinds of pain, head injury, and so forth. So there's really, there's no end to this list. I put up some of the most common ones, but really there's no end. So what are we to do about this situation? We have a patient in front of us that has multiple comorbidities. They also have a major sleep problem. Well, one of the things I would suggest you do is think about what is maintaining that problem. Because for many people, if you have had a sleep problem over 20 years, the causes of the initial bout are actually now quite distal. And what's really most helpful is to look at what is maintaining the problem. And one of the things we know that maintains sleep problems over time is something called conditioning and hyperarousal, of course. So conditioning refers to the fact that at night, as well as during the daytime, if we spend a lot of time awake and in our beds, the bed becomes a cue for us to be awake and alert. And over time, that becomes a very powerful stimulus control kind of mechanism that can maintain this problem. Similarly, when we've had a problem for a long time, it's very natural to get very hyper-aroused about it. And the hyper-arousal often is a very significant issue that helps to maintain this problem of insomnia. So what we sometimes talk about is causes are important, but maintaining factors may be even more important in addressing this problem and solving the problem. For many years, we often thought if we treat the comorbid condition, the insomnia will go away. But the data very clearly shows that just is not the case. For most of these problems, we can treat comorbid conditions such as depression or chronic pain, but the insomnia remains because there has been this well laid out conditioning and hyperarousal that has occurred. So that directs our focus to what the treatments are for chronic insomnia. And today I'm going to talk to you about the pharmacological and the psychological treatments, but we all know many patients that are using sort of herbal remedies to help with this problem, or hormonal remedies, melatonin. But that won't be the focus of what I'm going to talk to you about today. So the psychological treatment of insomnia, which has the most efficacy and the most support, is called cognitive behavioral therapy. And many of you are familiar with this approach. It's applied to numerous kinds of problems. And it's a little bit different application with insomnia than it is with, say, depression or anxiety disorders. And it looks something like this. And this is the model that we use with patients that many of them find it makes a lot of sense for them. And it starts with a problem of not sleeping for several days in a row. It causes a period of hyperarousal where a person gets upset about the problem, their blood pressure goes up a bit, they feel more emotional about the problem. And then what very naturally tends to happen is people start to worry more about the problem. They start to change how their perception of the problem. So it's very common with people who have chronic sleep problems to begin thinking that they're barely sleeping at all, or it's taking them a very long time to fall asleep. Then what can happen is people start to think about how much sleep they need, which often gets quite distorted, and by the media in part as well. People start feeling that if they're not getting 8 hours of sleep, that means that there's something wrong with them, and they're at risk for adverse health events. In fact, they may have never been 8-hour sleepers, but the expectations start to develop when a person gets hyper-aroused. And then individuals with this problem typically will start to monitor daytime fatigue like they've never done so before and really link it back to the night of poor sleep. So most of us know there are many reasons why we can be tired during the daytime. A boring job, too much stress, conflict with our spouse. But when you've had a problem like this one developing over time, typically there is sort of a singular focus on the sleep as a cause of fatigue. So all of those cognitive styles tend to lead to more hyperarousal. And then what can very naturally happen is a person picks up some bad habits, like they start to monitor the time at night to ensure that they're getting the amount of sleep that they think that their body needs. People can start to get into bed very early in the evening, try and catch up for lost sleep. And they can also start sleeping in as late as they can on the weekends, say, so the irregular sleep schedule often develops. There's many habits that are maladaptive in this cycle. One of the habits that we see a lot is people that basically become non-functional in the morning, so they'll refuse to set appointments. That might include coming in to see you for their consultations because they're so apprehensive about their ability to get up in the morning. So all of these things, arousal, cognitions, habits, tend to lead to consistent consequences, which for many people are fatigue and blue mood. So cognitive behavioral therapy aims to go at each of these different areas by teaching people how to reduce arousal, how to change what they're saying to themselves, and how to evaluate their habits to see if they're helpful or not. The gold standard treatment for insomnia consists of a series of techniques. And these techniques I'll be explaining to you in a bit more detail. But the techniques are called sleep restriction therapy. How many people in the audience have heard about that one before? Okay, so not very many. And I think what that highlights is that we don't actually know as much about how to treat insomnia as we might have thought we did. For many years, the thinking was sleep hygiene, and appropriate sleep hygiene was the way to sleep better. But now we know that sleep hygiene as a standalone treatment is actually quite ineffective. And in sleep studies, we actually use that now as our control group because we think it's a fairly effective kind of condition for people. So I'll be talking to you a bit more about what we know to be the most effective treatment techniques now. The second technique is called stimulus control, which is more of a goal than a technique. I'll talk to you about that in a minute. Relaxation training and cognitive therapy. Okay, so sleep restriction therapy involves really creating a state of partial sleep deprivation. And we do this because we think that one of the issues with people, if they haven't been sleeping over time, is they get a very sluggish or weak sleep drive. So what sleep restriction does is involves calculating a sleep window for a person, or a time we're going to want them to get into bed and a time we want them to get out of bed. So typically the first step in the sequence is to ask the individual to set a wake-up time that they can adhere to during the weekdays and the weekends. So this is sometimes challenging because these people are in the habit of trying to make up for lost sleep on the weekends. So you need to provide a rationale for why this is important to do, and let them know that typically this technique is very, very successful and likely to help them with their sleep if they can hang in there for a period of time and try it. So you have the person set a regular wake-up time, and then you would calculate their bedtime based on how much time that they're sleeping currently. So if a person is sleeping very little currently, say 4 or 5 hours, and they want to get up at 7 a.m., then their bedtime would be 1 or 2 in the morning. And typically when you announce that to people, their jaws drop in disbelief because right now, currently they've been attempting to fall asleep at 10 and lying in bed for, say, 2 or 3 hours, right? So that's where the sleep deprivation component comes in the delay of the bedtime. What sometimes helps people to adhere to this is to remind them that they weren't sleeping anyways, that they're just going to be doing something dull and boring and keeping themselves awake until the prescribed bedtime. And then at 1 or 2, they're to get into bed. And what they'll typically find is they'll fall asleep almost instantly and sleep very deeply throughout the night. And for many people, that success with doing that will allow them to maintain this particular technique. So after a few days of doing so, that 1 to 2 a.m. bedtime, we ask them to back up their bedtime and go to bed a little bit earlier in half-an-hour increments until they're back to a bedtime that they feel works for them and the sleep problem has not returned. So that is called sleep restriction therapy. It's probably one of the most effective techniques for insomnia, and it's also the one that very few patients have heard about before. So you have both the bonus of something new that they haven't tried before, something that's time limited, and something that they're likely to experience a positive effect very quickly. They can do that. Okay, the second technique, which is really a goal, as I mentioned here, is called stimulus control. And this involves the idea that we really do not want that bed to become a cue for awakeness and alertness. So I saw somebody just last week who was telling me with excitement in her eyes about how she would go into the bed around 7 o'clock with her son. They would cuddle, watch some of his favorite cartoons. She would work on a little work on the side. It was really a special time for them. And of course, what had emerged for her over time was a terrible problem with insomnia. And so I suggested to her that the bed should not be a base camp for activities in the evening. We really just want that bed to be a place to sleep and for intimacy, but not to engage in any other activities. And so what that means, of course, is that if you wake up during the night and you're awake for what you feel is an extended period of time, the best thing to do is to get out of bed to a place that you've got set up where you can do something boring and dull, and then when you get sleepy to return to bed. Because we do not want the person to be awake and alert in bed for an extended period of time. So that is called stimulus control, and that this is also a very effective technique in the area of insomnia, probably second in effectiveness to the sleep restriction. Something more familiar to many of us is the idea of relaxing if you can't sleep. And this helps a certain number of people with insomnia. These are the 4 probably most effective relaxation methods for people with sleep problems. Paced breathing, or breathing quite deeply from the stomach. Progressive muscle relaxation involves tensing and relaxing different muscle groups. Hypnosis is really just an extended paced breathing technique as we use it. And of course, mindfulness meditation, which is becoming more and more popular. Again, a technique that focuses on staying in the moment, trying to not be judging or striving to achieve something, and to refocus in the moment you're in rather than on your mind and your mental activity. So all of these methods are familiar to people that use cognitive behavioral therapy for insomnia, and many of the web-based interventions that I'll be talking to you about today also employ them. So relaxation therapies can be very helpful for a person who's hyper-aroused, as many people with insomnia are. I think this comic strip illustrates some of the process that goes on for some of us when we're not sleeping at night. I don't know if people can read that, but the top one says, if I fall asleep now, I'll get 6 hours of sleep and I'll be all right. And then at 3 a.m., if I fall asleep now, I'll get 4 hours of sleep and I'll drink lots of coffee. And then the third one is, it's 5 o'clock in the morning. If I wake up now, I can call in sick before anyone gets in. So this, for many people who have chronic sleep problems, this is the kind of thing that goes on during the night. There's a lot of bartering, a lot of trying to manage the anxiety of what's going to happen the next day. And so cognitive therapy is a big part of the treatment for insomnia. It's probably doesn't play as big a role as it does in the treatment of other kind of disorders like depression and anxiety. But in the area of insomnia, it really helps to be able to identify what you're saying to yourself at night. It's making you anxious and tense and making it less likely that you'll return to sleep. So we ask people to stop trying to sleep, and the sleep restriction technique is very helpful in that regard because really you're prescribing the staying awake. And typically people are very oriented to trying to sleep. So asking people to try to stay awake is often very helpful. You're nodding your head, you probably found that too. Yeah, so that technique can be very helpful. Similarly, some of the people with chronic insomnia are big worriers, but not all of them are. There's a small, there's a percentage that are. And we often ask them to schedule time to worry well ahead of bedtime. Because what can happen at night is when we have no distraction, our minds go right to our worries, when we're least able to cope with them and to deal with them. So these are some of the examples of the kinds of things that a CBT therapist would have an individual do if they had insomnia. As I mentioned, sleep hygiene is much more familiar to most of us and more familiar to people in the patients and so forth. And this refers to things like keeping the bedroom environment dark, quiet, free of other types of distractions, not overindulging in caffeine, and getting some exercise and things like that. So very good things to do, but we just don't find that they produce a very significant effect when we implement that on its own. So what does the literature look like for the effectiveness of this approach called cognitive behavioral therapy for insomnia, or CBTI? Well, these are results from 2 large meta-analyses show very large effect sizes for the delay in falling asleep or sleep onset latency, and moderate effect sizes for number of awakenings, or NOA, the time awake at night, or WASO, and moderate effects for total sleep time. Effectiveness in CBTI, there's now been 20 years of research on this particular intervention. There's been many studies and good evidence that these are robust effects and that they do persist for up to 2 years. We haven't had many trials that have looked at outcome beyond that. Of all the sleep variables, the amount of sleep people get tends to show the least improvement. And this is sometimes because, there's just a cap on how much sleep people need. People's expectations for sleep sometimes are a little bit out of whack. And sometimes the sleep restriction actually leaves them obtaining fewer hours of sleep, but better quality sleep, so they feel better overall. One of the things with this research base is that we definitely need more placebo-controlled studies in this area. So that's something for the sleep medicine field to look into. The American Academy of Sleep Medicine, based on a review of the literature, gives a grade B recommendation to these techniques, and citing that we need more placebo-controlled trials to move that up to A level. Now, the other option for you as a primary care physician when you have a patient with insomnia in your office is pharmacology, and there are several main classes here: the Z drugs, the benzodiazepines, the sedating antidepressants, and in Canada, and I understand the US too, sometimes people are using antipsychotics at low doses to capitalize on the sedating side effects. So we'll talk a bit about what the data shows for some of these particular agents. In 2011, there was a meta-analysis of 13 Z-drug studies, which were sent to the FDA. So the advantage of this particular review is that these were studies that were published and those that were unpublished, avoiding publication bias. So comparing the Z-drugs to placebo, finding that there were small effect sizes, so in the 0.3 range, that the biggest improvement was in the amount of time taken to fall asleep, and that improved by about 7 minutes, or 22 minutes using polysomnography. So that's assessment of sleep in a sleep lab where people are hooked up. Young females had the best outcomes, and there were no other significant outcomes in terms of sleep. So the Z drugs did not have a better impact on time awake during the night, total sleep time, sleep quality, daytime fatigue relative to placebo. But there were large placebo effects. So when you give somebody a Z drug, they're getting both the effect due to the drug and the effect due to the placebo. And together, combined, that produces a moderate effect size. Okay. Another meta-analysis looked at the benzodiazepines in Z drugs and concluded that there were moderate and equivalent effect sizes between these 2 drug classes. However, there was a number of adverse events. There was tolerance for benzos and rebound insomnia, and the potential for abuse and dependency, and that these issues really have not been studied enough, partly because a lot of the researchers who are doing the drug studies are employed by pharmaceutical companies, and there may just be more interest in demonstrating effectiveness than identifying problems. Working in a clinic setting with sleep patients, I see a lot of these problems with dependency really more than abuse, where people have started on a medication, often starting in a primary care office, and then many years later have tried many times to withdraw from the medicine but have not been successful, and are quite frustrated about that, both because they don't wish to have to take something to sleep, it's expensive, it sedates them, and it has interactive effects with alcohol and other medicines they might be taking. So side effects associated with medicines, we really hear patients talking about all the time in the clinic, but there haven't been as much detailed study of those. Until recently, the sleep field was criticized for there being sort of two camps of people, those that gave drugs to these patients and those that applied behavioral methods, and we didn't have a lot of data or information on which was better. So I'm going to talk to you about some results from a meta-analysis looking at comparing these CBTI to zopiclone, zolpidem, temazepam, and triazolam, some of the most common prescriptions for sleep problems. In all of these studies, sleep was measured using something called a sleep diary, which is a self-report of sleep, as well as either PSG or actigraphy. And for those of you unfamiliar with actigraphy, typically a person wears a motion logging device on their wrist, and the movements are considered to be a proxy for wakefulness. Okay, so it's none of those measures are perfect, but they're all going at the same thing. And what the meta-analysis showed was that CBTI was more effective at the follow-up than any of these medicines. And the kinds of change that would be seen, was typically seen, was 30 to 45-minute improvement in how long the person was taking to fall asleep, 30 to 60-minute improvement in their total sleep time, and an improvement in their sleep efficiency, which means how much time they're asleep versus how much time they're in bed, of 8 to 16%. So some of this data was very interesting because this is a problem that many of us have in the actual clinic in terms of what to do when a patient comes to you and they want to have they want some treatment for their sleep, they might want to have pharmacotherapy, you're aware of the availability perhaps of CBTI and you're not sure which way to go. Well, this study quite clearly showed that for all of these studies, the CBT was the more effective way to go. Also, patients at the end of the follow-up period were asked about what did they find to be, how satisfied were they with their treatment, and we found that the patient ratings of satisfaction were significantly higher for CBTI than medicine. So although patients may think that they want medicine, when they actually try CBTI, they typically are much more satisfied with the effect. So having said that about the different treatments, what is the impact of treating sleep on comorbid disorders? Because insomnia is frequently comorbid with other things. And the three problems that have probably had the most study, although this area is just emerging, are depression, anxiety, and chronic pain. I'm going to present also some data for you today on a trial we are doing with type 2 diabetes. So the most studied condition in this area is a major depressive disorder, and there's been a number of studies that have looked at what happens when you treat the sleep problem in these people. And what results these studies have shown that treating sleep lessens depressive symptoms, it lessens suicide risk, and it lessens the risk of developing a subsequent depressive episode. There was a very interesting study out of Stanford that looked at the impact of giving an SSRI and CBTI to patients with major depressive disorder versus the same SSRI and sleep hygiene recommendations. And what they found was that the group that had CBTI and the SSRI had a 62% remission rate versus a 33% remission rate. So this was very interesting data to show that treating sleep in major depression may really help the person stay out of the woods for depression. Similarly, a pharmacotherapy trial by Fava et al. showed that if you give zopiclone and an SSRI to people with depression, you have a 42% remission rate versus placebo and an SSRI, 33%. Okay. In the area of anxiety disorders, there have probably been 40 studies that have looked at the impact of treating insomnia on people with this problem, and we find that just like with depression, treating insomnia lessens anxiety symptoms with effect sizes sort of in the range of 0.4, reduces absenteeism from work because having an anxiety disorder and sleep is a big predictor of not going into work. Having lessens suicide risk and lessens relapse rate. And a study by Polak in 2008 looked at the impact of giving medicine to people with anxiety disorders as well as zopiclone, and found that that combination lessened anxiety symptoms and improved remission rates compared to a placebo. So 63% versus 49%. So if you have a patient with depression or anxiety, it really makes sense to treat that insomnia directly. Similarly, in the area of chronic pain, we know that treating insomnia improves alertness, executive function, fatigue, and it also reduces pain interference and pain catastrophizing. But this particular study found no change in actual pain severity. So some of the factors that might be maintaining chronic pain will be improved if you treat the sleep problem. In our own clinic, we are right now embarking on a trial to see what happens if you treat insomnia in people with type 2 diabetes. And we've now actually included type 1 as well. So this is a web-based delivery of CBTI. So what happens here is people in the comfort of their own homes log into our website and they work through those gold standard components over a 6-week period. So they'll log in once a week, they'll watch a video that describes some of the content, they have some homework assigned, and they come back in and report on their adherence and their sleep. And we're comparing that to a group that gets stress management, and the control condition or this stress management treatment involves people, again, logging on for their home for a comparable amount of time, and they're asked to please tell us a little bit about what it's like to live with diabetes. And so it's sort of a catharsis kind of writing intervention. What we found so far is that fatigue and time awake at night is significantly better in the people that are receiving the sleep intervention versus the stress management intervention. And that people's ability to cope with diabetes, they're reporting much better ability to cope with diabetes, much more control over diabetes, and fewer beliefs that their diabetes will worsen over time if they receive the sleep intervention relative to the control intervention. Fortunately, I don't have the data on blood pressure and blood sugar, but of course we're collecting that as well, and this is going to be a trial where we're going to follow up for 2 years. So the data, the self-report data at this point looks interesting, and although people with diabetes are dealing with a number of health problems, the biggest challenge, of course, is getting these people to adhere and to take on another task. However, the CBTI has very minimal level of involvement per week, so a person would take about 15 minutes a week to work on this program, so it's not time intensive. Here are some of the most common problems in primary care, and there's many others, of course, we could add to this list, but as you can see, many of these overlap significantly with sleep problems. And I think what you're going to see in the coming years is there's going to be more and more study of the impact of treating sleep in these problems. So if any of you are researchers, this is a really ripe time to get involved in seeing what happens if you treat insomnia in some of your patients with these problems, because we really need this data. It would be very helpful to see what kind of impact treating insomnia will have. So who's a candidate for this psychological treatment for insomnia? And the answer to that is many people are candidates, probably more people than you think. People with primary or comorbid insomnia, people who have sleep that exceeds that which is normal, so people who are both oversleeping, people that are medication dependent, typically a person who's very tired at bedtime but gets into bed and says, but I can't understand this, then I'm wide awake. Well, that is really a perfect candidate. That's a person that has really become conditioned to wakefulness. People that have really erratic sleep cycles where they're sleeping till all hours one night and not the next and so forth. And people that, of course, are very hyper-aroused or very tense are very good candidates for this kind of therapy. So who's not a candidate? Well, there also are people who are not candidates. Anybody who depriving them of sleep in a temporary basis makes their condition worse is not a candidate. So these might be people with seizure disorders, people who are manic or propensity to become manic, people who are psychotic. Okay? Similarly, one of the interventions in the stimulus control area asks people if they've been awake for an extended period of time to get out of bed and to go to a place until they're drowsy again. So people who are at a risk of falling might not be good candidates for that particular technique. And shift workers who are people who are their shift cycle is changing all the time need something different than this traditional CBTI for insomnia. Of course, we can all think of other people who might not be good candidates. So this is an example of a narcoleptic who's maybe looking for a screaming baby or car alarm CDs rather than relaxation CDs. Okay, then we have a feasibility issue, or how can we deliver this type of treatment to people in primary care when the average consultation time in Canada, at any rate, is about 7 to 10 minutes. So, there's just very practical issues that need to be addressed to think about how we can get this out to people who need it with this clearly effective treatment. Face-to-face CBTI is expensive, it's time-consuming, and it's less available, and I understand that's particularly true in this area. Delivery of this treatment via the web is less expensive. As I mentioned, it's less time-consuming for the physician or practitioner, and also, though it can be less available. There's only a handful of these programs that are available in the world. Telemedicine, which is I think the form we're using today, we use in Canada fairly often now, but it's quite expensive for use, and it's time-consuming. You're not really saving the practitioner any time, they're just communicating over this different media. And in many sites, telehealth is just simply not available. So I wanted to give you some data on a study we're conducting right now that compares these different delivery formats to look at how effective they are. And this is a study that we're just getting ready to submit with 78 people who live in the rural area who have chronic insomnia. So we have an arm that has received CBTI through telehealth. An arm has received CBTI through logging onto a computer in their homes to our website, and an on-site group of urban dwellers. Okay, and what we have found at this point is that there are no significant differences in effectiveness between these different delivery formats, but everybody's sleep becomes more efficient, which means they're asleep more of the time relative to how much time they're spending in bed at the end of the program. Sleep quality, again, has improved. These sleep quality ratings, 2 is moderately good sleep quality, 3 is very good sleep quality, 4 is outstanding sleep quality. We never get anybody that responds 4. But as you can see, there's no significant differences between the groups over time, and all of the groups are having better sleep quality at the follow-up period. One of the interesting findings is that it looks like the daytime fatigue outcomes may be better for the group that received the telehealth. So that was sort of interesting over time. There's more of a significant drop there. Okay. How accepting are people of different delivery formats? How accepting are people to the idea of logging on from their home to work on their sleep? Well, we have found that people are very accepting of this. This is a sample of people that were referred to our outpatient sleep clinic. That 67% were interested in this. Of that particular group, 11% didn't have a problem anymore with their sleep, so we took them out. 11% had no access to high-speed internet. 4% lacked comfort with computers, but only 3% of people preferred in person, which was quite interesting. And I think many of us have the attitude that patients want to come in and talk about problems. So it's curious, and we should be open to the idea that maybe for some kinds of problems, like sleep, they're quite happy to work on it on their own. And only 2% of people were not interested. So in this sample in Canada, people are very interested in web-based delivery. And this is some patient satisfaction data from the telehealth study that shows that 90% of people were mostly or very satisfied with the treatment being delivered in these different ways. And a few were dissatisfied, some were indifferent. So overall, patients are very satisfied and accepting of CBTI. And what we have found after using web-based and telehealth delivery for a number of years now is that physicians now are referring to us specifically for web-based delivery because their patients are asking for it. It's very quick and easy to access, and it frees up their time in the primary care office. So we have now fully incorporated this, and I think we're the only public health system in the world that incorporates web-based delivery of sleep services to much success. So when people get referred to our program, the first thing they get approached about is if they're interested in trying a 6-week web-based program from their home to work on the program. If at the end of that they still wish to come in, we'll see them on-site for a 1-session appointment. And if at the end of that appointment they feel like they need more treatment, we concur, they would be accepted into a 6-week on-site group. And at the end of the group, if they still need help, we would see them individually. So here's an idea of what happens here. So with Step Care, the idea is you provide the lowest cost treatment to the most people you can in the initial steps, with the idea that you only provide specialized services and expensive services to people that really need it. And this seems to be working very effectively in the sleep area. So we are able to take out about 50% of people after they've done the web-based delivery. So after doing the 6-week program, 50% feel like they no longer need any more assistance. Then of the group that we see for the in-person consultation, that often involves just reviewing what they learned in the sleep program, what was helpful, and encouraging them to keep doing that. Because for most of us, we can lag with our motivation and adherence. And sometimes all we need is someone else to remind us, yes, that was helping, and you need to do it, keep doing it. And that's, for many people, that's enough. And so now we see only 23% for the really expensive on-site group treatment. And just to let you know how that compares, prior to the development of the Step Care model, we were seeing 71% of people for on-site treatment. So that is an enormous increase in efficiency, and it was for that we were given a national award from Accreditation Canada that goes around and vets hospital programs across our country. So this has been a huge time saver for us at a clinic level. It has also increased the volume of people we've been able to see, but cut down on the direct time costs that we've had to pay. We have recently begun a pilot study in primary care where we prepare brochures for physicians to give to their patients with sleep problems that talk about the web-based program that we've implemented and talk about the cost and how much time it would take and hand that out to patients. And we also have another arm that's just had posters in the waiting area for patients to read about. Okay. So once the patient completes the program, a discharge summary goes back to the physician to let them know how they've done. Here's what the brochure looks like to describe what insomnia was to patients, what the treatment program looked like, 6 weeks, what was in the modules, and what they would be asked to do. Keep a sleep diary, log on once a week, kind of thing like that. Okay, so what the feedback we got from the pilot was that the physicians were very interested in continuing to refer. They handed out a large number of these brochures. The physicians like the potential to reduce the prescribing of hypnotics because in Canada, physicians are increasingly finding that people, once they begin a sleeping agent, are often on that sleeping agent for 20+ years. And that there's lots of problems with falls, with other kinds of adverse events from the medicine. And so they're very interested in reducing their patients' use of these hypnotics. The physicians also told us that they were surprised that it took no time from their clinics. So they didn't have to respond to very many or any questions from patients about the program. And the physicians asked us for advice on how to motivate people to pursue behavioral treatment, which of course is the question that we're all wondering about, is how do you get patients to consider switching what they're doing in terms of this problem? So sometimes it helps to talk to people about asking them, are you interested in getting control over the problem of insomnia? People will often say, yes, I'm very interested. You know, would you like to do it in a way that's as cheap as possible? Yes, I would like to do that. I've got the solution for you, here it is. So you kind of lead them down the path of things that they would agree with that naturally make sense. Sometimes people are persuaded by data, and data on our program shows that 80 to 90% of patients say they're improved after they do CBTI for insomnia. So sometimes for many people, well, that's convincing enough to let them to give it a try, encourage them to give it a try. So the conclusions about that from today are that insomnia really is a very as I mentioned, some people have referred to it as an epidemic. It's very, very costly not to treat this problem. So just like fever, not treating insomnia, we are now increasingly finding that there's many adverse effects that will follow. We have effective treatments, in particular behavioral treatment for this problem shows the most durability and long-term effectiveness. And implemented in primary care, it frees up your time to deal with other problems. So it seems like it's a natural marriage, CBTI for insomnia and primary care. And that leaves me with to the end of my slide. So it also, other than freeing up time in primary care, it also frees up time to do other things that you might enjoy. So thank you very much for your time today. Yeah, are there any questions? Yes.
Could you mention any correlation of diabetes or insomnia with, sorry, you didn't mention any correlation of diabetes and insomnia with sleep apnea.
Yeah.
And do you screen these people for sleep apnea? Do you give them sleep studies?
Yeah, in our particular study, they were all screened for sleep apnea. So we accepted people into the study that were being treated for sleep apnea. But sleep apnea is a common comorbid condition, with certainly with diabetes, the most common. And what we have found there is CBTI helps individuals with sleep apnea. It won't reduce the number of arousals that they have, but it does help them to feel like their sleep quality improves, which is interesting, I think.
When you said 100% that entered that study, did you pre-screen them for contraindications to CBTI? I'm assuming.
Yes, we did. So when they call us, we screen them for those particular things: suicidality, psychosis. Are they manic? And then if they are good candidates, they get accepted into the program. I'll let you know, we end up screening out very few people based on those criteria, but that's what we do.
And I have a second question. For people who have had long-standing insomnia that don't recognize that they have an insomnia problem necessarily, how do you address those people? It seems like it might be slightly different.
Yeah. So they're not complaining about the problem, is what you're saying, yeah. Well, we often don't see those people because if they're not complaining, they haven't got to the healthcare system and they haven't ended up at our door. But I think some of the things you could talk to them about are what kind of problems they are having and how sleep could relate to those problems, just to start broadening their awareness of the links between sleep and whatever issues they are experiencing.
I didn't hear you mention, perhaps you did, about tinnitus and how that might impact one's ability to sleep. Have you studied that? Have you seen that these techniques have an impact on those who have sleep difficulty related to that problem?
Yeah, I've seen working actually right now with a couple of people with tinnitus. So the thing with tinnitus is you have this just enormous level of hyperarousal in those people, which I think is what maintains the problem. So those folks need to have double or triple the amount of time spent on relaxation therapies, and probably need, after this program, if there's lots of residual difficulties, some specific work on tinnitus-related adjustments. So it's a very common comorbid condition. CBTI will help with some of that, but they need extra emphasis. They probably need to redo that module on relaxation for a number of weeks.
And the keeping the sleep diary, it would seem to me that if I'm thinking I have to keep a sleep diary, that would cause hyperarousal and interfere with sleep. I wonder how do you suggest people actually do that?
Yeah, that's a very good question. And there's a small minority of people that get very, typically they're obsessive people, and they get very upset by paying attention to a problem. So like most monitoring systems, we tell people it's very normal to have some anxiety initially, and most people find that that goes away as they get used to doing the monitoring. And that is in fact what happens. But occasionally, there'll be a person that that's just not a good idea, that they do the monitoring, and that's okay. They just tell them not to do the monitoring. But this program will still be very effective, even if they're not monitoring the sleep. It's a good question.
Other questions?
Can you tell me a little bit about your experience with people whose primary language is not English? Is there there any options for them at this point?
Yeah, at this point, no, although I think there are some adaptations that are being made for people who speak Spanish, but at this point, no. Yeah, it's an English-based program. We try to keep the reading level as low as we can. We do lots of repetition and accompanying PDFs to read, so if hearing the spoken word is more challenging than reading, we have that option as well. But yeah, it is, it's an issue.
And what is the interaction between the therapist and the module and the patient? So once they get started on the module, how do you progress?
Right. So once you log on each week, you'll watch a module where the therapist is talking to you. And so that's the only involvement with another person, is just watching those videos. And people typically develop a relationship with the person on the video. We have a point person that they can contact if they have a question that comes up. And as I mentioned, that very seldom happens. Typically it's a lost password. That is by far the most common thing. But this program was basically developed to run independently without person contact. And in some areas like depression, anxiety, sometimes that's you need more human contact or support. But in the sleep area, what we're finding is that in fact you don't. That people actually can work on this problem often on their own without much assistance.
That's great.
Which is interesting to know. But again, we didn't know that going into it. How much involvement would be needed.
Yeah. And just one last question about the changing their medication usage once they start to sleep better. Is that just a conversation that develops with the primary care physician?
Yeah, that's right. Depending on the modules, the program that we use in Canada, we give people information about how do you go about tapering off a sleeping agent. And that involves consulting with your doctor, and it involves a very slow taper. And we talk to them about the cycle there, how to proceed, which is go down to one medication for sleep only. Once you're down to that, start reducing the dosage by a quarter. Do that for a number of weeks, and we typically think of it taking about 3 months for a person on 7.5 milligrams of zolpidem to taper off. So we tell people expect it to take a long time, and the last thing you want to do is cut off something cold turkey. And then once you get down to the lowest dose, think of taking a drug holiday. We call it a holiday, so we're trying to create a positive bias. Starting on the weekend, you don't have too many obligations, and do that for a number of weeks and start expanding the holiday. And we have had reasonably good success with that. It's a question of readiness, just like smoking cessation, I think. When some people are ready, they're ready, and then they're ready to go. But if they're not ready, it's going to take longer to proceed that way. Yeah. Question?
Yes, I was interested to hear any experience working with individuals that have varying degrees of dementia.
Yes, that's a good question. I do not believe there have been any studies yet evaluating CBTI with dementia, but I have seen people over the years with mild cognitive decline that seem to be doing quite well with this program. Now, when it becomes severe, that's another matter entirely, so I'm not sure what we can say about that, but in the mild stages, this program is definitely effective.
I think we have just a couple questions from online. First is, could you please explain the mechanism involved in improvement of depressed mood, even temporarily by sleep deprivation?
Right. So there have been some studies that show that if you deprive people of a night of sleep, there's a temporary mood rebound. The mood improves, but then the data shows that the mood returns to baseline, or people's mood becomes depressed again. I'm not sure of the mechanism with that in terms of the brain chemistry, because I think it is a brain chemistry mechanism. So I wouldn't want to speak to that yet, but I'd be happy to find that information for the individual and forward it to them. But I don't think it's an enduring effect, so for that reason, it's not something that we recommend.
Another one, are there different impacts of the insomnia CBT when it is used with different populations? For example, race, socioeconomic status, etc.?
Yeah, different impacts. We have done some data looking at what moderates outcome for the web-based delivery, and we have not found that age, education, or gender impacted the results. So that means that we have an age range from 18 to about 82, And we did not find that people who were older fared less favorably, nor did we find that people who were less educated did more poorly. So we haven't really been able to identify many moderators, and that fits with the in-person literature, which generally has found these techniques to be quite robust, and they do not seem to depend on the person's background in those ways.
Just two more here. What type of support have they provided to individuals participating in the web-based version?
Yeah, so we do not provide any kinds of phone support or, of course, no face-to-face support just because we're looking for the cost-effective model. But we do have someone that is an online coordinator, and this is the person that gives them the username and password in an email. So it's emailed to the individual. And then the person has emailed the individual at midway through the program to see if there are any questions. And as I mentioned, there are rarely any questions. The main issue sometimes is around password access. So it's been very minimally supported. Now, if you added support to a program like this, probably, we don't know, probably the outcomes would be different, might be better. We don't know, it's an open question. But at this point, the outcomes are quite good for a low cost investment in terms of clinician time, which is what we're really interested in.
And one more. What are the distinguishing characteristics of the 7.9% who benefit only from individual treatment? It goes on, the goal would be to screen in only those who need individual treatment for referrals.
Yeah, that's an excellent question, and we just do not have enough data to answer it yet because we have so few people that actually proceed up that pathway. And as I mentioned, we're one of the only sites, I believe, that is actually operating with a step care model in the public health setting. So I think that is to be determined. My sense of that is people that are in an acutely stressful situation, like going through a highly contentious divorce or up against some major legal charge. Over the years, if I think about that, those have been the people that we have seen for an additional individual appointment or two. So it's acute stress would be the predictor. And there's a couple more questions up here too. Yeah, well, for the clinic, and we've done a number of studies in the clinic, but the clinic collects people 18 to 82. Let's see, 50% of them are grade 12 graduates. The ethnicity ranges from, as I mentioned, the regional range. There's lots of people, minority groups are well represented. Does that address your question?
So the majority of your population pretty much were above average in terms of reading level of education. The population over here may be a little different.
Yes. Yeah, that's a good question. Yeah, so that may be the case. However, I will draw your attention to a study that we published last year where we looked at whether education did moderate outcomes, and we did not find that. But if you were having a patient who was having trouble with understanding things, then some extra support or handouts would certainly help that outcome. Yeah. It's tough trying to create a program that meets the needs of a wide variety of people, but it's very important. So it's a very good question. Thank you.
In the studies you mentioned,
yes,
there were some pretty impressive effect sizes. I'm curious as to what sorts of endpoints were used. I mean, were you looking at people in the community with self-reported data, like changes in numbers of hours of sleep, with daytime symptoms? Were these studies looking at controlled environments with electroencephalographic data or polysomnographic data? And if it was, symptoms like daytime symptoms and improvement of somnolence, whatever, were these improvements with CBTI independent of changes in sleep?
Well, improvements with CBTI wouldn't be independent of changes in sleep because we were targeting the sleep. But most of the data that I talked to you about today were both self-report and some other kind of more objective method of assessment, so the PSG or the actigraphy. So a lot of those, you're right, they are impressive. There's very significant effect sizes from these treatments, measured using multiple dimensions, and we look both at daytime functioning and nocturnal functioning. Yeah.
Did you look at the duration of treatment that they would have to be on, the duration of therapy, and what is the efficacy after the therapy was stopped?
What was the sort of relapse rate? Is that what you're speaking about?
Like how long would they have to be on the therapy, and what would be the relapse rate
Yeah.
if it was stopped?
Well, for the psychological treatment, the average treatment duration is 6 to 8 weeks, and that's quite standard. I don't think there's enough information about relapse rate in psychological treatments, so that's an area of study that we need to go into more. There's more information about the pharmacological treatment, and the relapse rate is quite high, actually. Once a person discontinues off a sleeping agent, the chance of them relapsing is more than 50%. Good question. Yeah. Yes, Seth?
That actually made me think of a question, which is you talked about tapering. So in your experience, if you succeed in tapering, which I assume is only a minority of patients to begin with, does the CBTI seem to serve as almost a vaccine against relapse in those patients, or do you not have enough? This would be anecdotal data, I guess.
Mm-hmm. Yeah, it's tough to know because once we conclude with them, we
showed data that the meds only work minimally anyway. So
right. We have to see them again, but many people, I will say, after we have concluded treatment with them, report back to us at follow-up points that span upwards up to a year that they actually are doing better than they were when they finished, which is something surprising to us, and we haven't always known how to understand that, except that maybe they're getting more opportunities to practice or they're getting better at implementing some of the strategies. But there's just people are majorly happy when they're able to discontinue off their sleeping agents. That's for sure. So I can't answer that question with data. Yeah. Okay, thank you.
Thank you very much, Dr. Wilson. That was very enlightening. Just two comments which I had. I mean, there was not questions, but if she wants to add, something at the cause of insomnia, being a medical resident should be one of them as well. They speak for themselves. And just for the residents, just to clear up, Zopicon, the drug that the doctor was mentioning, that's usually used in European. We don't have the FDA approval in the United States for that. But it's just equal to the Zopicon that we have, which is Ambien. So just don't get confused that we don't have this drug. Again, thank you very much for all coming. God willing, we'll see you next month with a different speaker. And thanks a lot, and have a nice day. Thank you.
I just wanted to make sure everybody that is here looking for CME, whether you're physician or non-physician, please be sure you've signed in if you came in late. And the process is we will be emailing you the login information to complete your survey, after which you'll be able to get your certificate printed at home, and that'll be the end of the process. Thank you very much for coming.
The same goes for anyone who was participating online. We will be emailing everyone who participated a link to complete the survey and earn the credits. Thank you so much. And for anyone who didn't get a question answered, I am going to print them out for Dr. Vincent, and hopefully she will be able to get answers to you. Thank you.